Hi, I'm Dr. Sheila Reyes from the Philippines, and I'm reporting live for Room Now here at Washington, D.C. for the ACR Convergence 2024. I'm here with Professor Walter Maksymowych from Alberta, Canada, and we will be talking about their study, abstract number 821, on answering the question of what is a positive MRI in spondyloarthritis. So let's get to the meat of the discussion. Professor Walter, thank you for joining us this afternoon.
Pleasure.
So congratulations again to your study and to your presentation. It was presented earlier. So now I would just like to ask, could you give us a brief overview of what this study is about and probably the reason why this was done or this was pursued?
Thank you. So MRI is really important in the assessment of spondyloarthritis. It's the most sensitive tool that we have, and it's really the best way to make an early diagnosis. But it's not an easy tool, it's not an easy scan to interpret. And both rheumatologists and radiologists often lack the experience to do the interpretation. And so it's really important that we try and establish some operational rules that might help radiologists and rheumatologists understand if they should be thinking about spondyloarthritis when they're looking at a scan. So there are different types of lesions, both inflammatory and structural lesions, that can occur on a scan. And the question that we posed when we thought about the study was, well, can we find a way of operationalizing the extent, how much of the sacroiliac joints should demonstrate, for example, bone marrow edema or erosion? So how extensive does it have to be before you start thinking that maybe this is ankylosing spondylitis?
Okay.
Now, minor degrees of inflammation can occur, for example, in very active people. So some people have called this bone contusion.
Okay.
But minor degrees of bone marrow edema can occur in healthy people if they're very active, for instance. So what we wanted to see, is there a way where we could look at defining, well, what's the extent of a lesion before we really start thinking it's axial spondyloarthritis. So what we did was we had a whole bunch of scans from people with spondylitis and different variants of spondylitis, like spondylitis plus psoriasis,
All right, so the other
Iritis
clinical...
and other subtypes. And we had non-specific back pain controls.
Okay.
And readers were evaluating the scans, but they were blinded to the diagnosis. And they were doing two things. First of all, they were just looking at the scan, all the sequences that were done, and they were doing two things. Number one, they were responding to a question in the case report form that asks, do you think this scan is indicative of axial spondyloarthritis?
And that's just based on the image that they're looking at?
And that's just a global assessment of the image.
Okay.
And then what you can do is you can divide each sacroiliac joint quadrant into quadrants using a line through the joint cavity and then through the midpoint of that line. So there are 4 quadrants. And then you can evaluate consecutive slices. So typically there's about 12 to 15 slices through the sacroiliac joint. And then you're going to ask the question, well, how many sacroiliac joint quadrants with bone marrow edema, erosion, fat lesion,
sclerosis,
best reflect the diagnosis, right? And differentiate between spondyloarthritis and a non-specific back pain control.
Okay.
And what our findings were actually something that's kind of easy to remember. And so it's the 3-4-5 rule.
Okay.
3 sacroiliac joint quadrants with erosion gives you specificity of 95% in favor of ankylosing spondylitis versus non-specific back pain. For bone marrow edema, it's 4 sacroiliac
Okay.
joint quadrants, and for fat lesion, it's 5
It's fine.
sacroiliac joint quadrants. That's why it's the 3, 4, 5 rule. So it's something easy to remember because those are amongst the commonest lesions.
Okay.
Erosion, bone marrow edema, fat.
Fat.
And so we call it the 3, 4, 5 rule that gives us really good discrimination between an MRI scan from a spondylitis patient and a non-specific back pain control.
Okay. So wow, that's very good, and the findings are really interesting. And now that you're saying that 3, 4, 5 rule, it's easier to understand. And I don't know if this was included in the study, but does the specificity further increase if you include a history of a patient with inflammatory back pain, or is it independent of the findings on MRI?
This is just purely focused on the findings in MRI. This is a radiologist or rheumatologist who may be looking at the MRI scan and won't have a history or a physical exam.
Okay.
And that's usually the case, of course, right? The
Yeah.
amount of clinical information provided to the radiologist is fairly minimal. Maybe age, there may be gender. Occasionally it may be B27 finding or a CRP, but usually it's only age and gender. That's all
Yeah.
you've got. And so this is just like an MRI scan. Now, this isn't something that's kind of should be interpreted as written in stone.
Mm-hmm.
It's guidance,
Okay.
right? And at the end of the day, the rheumatologist makes the final decision based on the history, the physical, the labs, and the reporting from the radiologist. So this is meant to help make that decision. Well, how much bone marrow edema, how much erosion, before I really get concerned that this is spondyloarthritis.
Yeah, correct. And it's because sometimes it depends on the reader as well. So I like what you
Yeah.
said about getting everything in context. So there should be your history that should be appropriate. And then, of course, make the use of imaging, because we know that imaging is really an integral part of the diagnosis and spondyloarthritis. Okay,
Yes.
so I'd just like to sum up what you've said, because it's really, well, if you take a look at it from your point of view of how you said it, it's really easy. The 3, 4, 5 rule. So again, that's 3 3 erosions,
Yeah.
3 lesions, erosions, and then 4 bone marrow edema
Yes.
lesions, and 5 fat lesions. Correct?
correct,
That
yes.
that could tell you or increase the specificity that this may be spondyloarthritis on MRI.
Yeah,
Correct?
it gives you more confidence.
Yes, it gives you more confidence.
So once you start seeing those targets, if the bone marrow edema is only in 1 or 2 slices,
Yeah.
you're probably not dealing with spondyloarthritis.
Correct.
Right?
Yeah.
If all you see is a couple of slices of bone marrow edema without erosion, without fat, this is probably not.
Or probably just a mimic, right?
Yeah.
Yeah.
And if you think you're seeing erosion in maybe one location, that's probably not bone marrow,
Not
spondylitis.
Okay.
So it's really giving some guidance about how extensive these lesions should be before you really start getting concerned that this is spondyloarthritis.
Okay, so thank you very much, Professor Walter, for joining us this afternoon and sharing the findings of your very interesting research. So again, ladies and gentlemen, remember that in the diagnosis or in the assessment of patients, when we consider spondyloarthritis, we have to take into consideration also, apart from an appropriate history, PE, then we also request for imaging, which in this case is MRI. And Professor Walter explained very beautifully how they came up with the diagnosis of MRI with the 3, 4, 5 rule. I'm Sheila Reyes, and follow me with my X handle at Rumarampa. and tune in to Room Now for more updates on the ACR Convergence 2024.